I am Dr. Nisreen Moideen from Department of Radiodiagnosis, Pushperi Institute of Medical Science and Research Center, Tiruvalla. I'll be taking a small session on genitourinary system imaging. Let us begin with the anatomy. Urinary system comprises of kidney, ureter, bladder, and urethra. Here we see the urinary system diagrammatic representation. This is the anterior view, this is the posterior view, and the sagittal view. On anterior view, we can see the suprarenal glands sitting on top of the kidneys, the kidney, ureter, bladder, and urethra. On either side, we have got different organs situated further superior to the kidneys. On left side, there is the spleen, while on right side, there is the liver. Next, we see the anatomy of reproductive system. In males, there is testis, epididymis, vas deferens, ejaculatory duct, prostate, seminal vesicles, and penis. While in females, there is uterus, salpinx, ovaries, cervix, and vagina. Male reproductive system. Here we see the testis in the scrotal sac. On top of the testis, the epididymis. Then on the vas deferens, prostate gland, seminal vesicles. Female reproductive system, we can see the uterus, the cervix, the vagina, the urinary bladder sitting anteriorly to the uterus, and the rectum posterior to the uterus. On either side, ovaries and the fallopian tubes. So, coming to the main organ of urinary system, kidneys. Kidney is a bean-shaped organ which is convex laterally and concave medially. It has got a length of about 11.5 centimeters or else 3.5 vertebral bodies and a width of about 5 to 8 centimeter. The thickness of kidneys come to about 3 centimeter. Kidneys are retroperitoneal organs spanning between T12 to L3 vertebra, and generally the right kidney is about 1 centimeter lower than the left kidney. The reason being the liver pushing down the right kidney. So this is the kidney diagram comprising of the cortex and the renal medulla. The medulla consists of approximately 8 to 18 renal pyramids, and these are opening to the minor calyx and then the major calyx, which are opening to the renal pelvis and then the ureter. In between the medulla, we can see the sinuses, renal sinuses, comprising of fat. This is the basic unit of the kidneys, that is the nephron. This is the glomerulus, the Bowman's capsule, the proximal convoluted tubule, the loop of Henle, and the DCT, which is opening into the collective tube and then opens into the minor calyx. There is also a vascular channel going parallel to the loop of Henle in each nephron. Again, another diagram representing the same. So ureter has got a diameter of about 1 millimeter to 1 centimeter. The length is about 25 to 30 centimeters. Again, ureters are retroperitoneal, and there are three normal constrictions to the ureter. These are at pelvic-ureteric junction, and then the pelvic brim where the iliac vessels cross the ureter, and finally at the vesico-ureteric junction. So again, our representation of the KUB system, that is kidney, urinary bladder, ureter, and the bladder, and then the urethra. So talking about the urinary bladder, it is the reservoir organ for the urine. It lies posterior to the pubic bone. The position of the bladder when empty is in the pelvic cavity, while when it is full, it extends to the abdominal cavity. And the urinary bladder has capacity is about 350 to 500 cc in an adult, while in children it is given by the equation of the age in years plus 2 the product into 30 cc. This is the picture of the bladder anatomy. Here we can see the ureter opening into the bladder at this point, the vesicureteric junction, and this is the bladder. The bladder wall is muscular, comprising of detrusor muscle, and the outer covering will be the peritoneal lining. And this is the trigone of the bladder, that is the base. Then the opening into the urethra. This is the bladder neck, and this is the prostate gland surrounding the urethra, lying inferior to the urinary bladder. So, talking about the urethra length in male is about 17.5 to 20 centimeters, while in females it's a very short, that is about 4 centimeters. Male urethra is divided further by inferior aspect of urogenital diaphragm into anterior part and a posterior part. Anterior part comprises of cavernous or penile part, that is more distally, and then the bulbar part. Posterior part comprises is short, and it comprises of a membranous part and the prostatic part. So here we can see the diagram of urethra. From the this is the bladder. From the bladder neck, the urethra begins. The first part of the posterior urethra, that is the prostatic urethra, which is surrounded by the prostate, and then comes the membranous urethra, which is the shortest and narrowest portion, and further down we have got the anterior urethra, that is the bulbar and the penile urethra, and finally the urethral opening. Again another diagram, the bladder, the vesicureteric junctions, trigone, opening into the urethra, the first part, the prostatic urethra, and here we can see the prostate gland, that is in males. You can see the prostate gland. This is on the right side. What we see is the female urethra, about 4 centimeters, while on left side we see the male urethra. So the prostatic, membranous, bulbar, penile. So, imaging modalities for the evaluation of the genitourinary systems include basically the plain abdominal X-ray, then intravenous pyelography, retrograde urethrography, cystography or urethrocytography, bipolar urethrocytography, voiding cystourethography, ultrasonography, CT scan, and the MRI. Then comes the nuclear imaging and hysterosalpingography. So I'll be talking about I'll be talking only about a few of these in this session. Firstly, the plain abdominal X-ray. It is a routine investigation for the evaluation of the KUB. Good quality films will show the kidney outlines, where we can evaluate for enlargement caused by a mass or hydronephrosis. Then we can look for calcifications. Opaque calculi in the kidney, ureter, or bladder can be identified on plain X-ray. Also, we can see for nephrocalcinosis, which is calcification in renal parenchyma. And on X-ray, we can also look for air distribution in the bowel to identify sentinel loops. So this is a normal KUB X-ray. So this is usually taken from just below the diaphragm to up to the pubic symphysis. So here we can see the renal outlines are faintly seen on every KUB X-ray. This is the left kidney, and this is right kidney. This is the outline, and this is the outline of the liver, spleen, and these shadows are cast by the psoas muscles on either side. And these are the bones, the lumbar vertebra, the sacrum, the ilium, iliac crust, the pelvic brim, and here we find the bladder. So, okay, the right kidney, the left kidney, the urinary bladder. So this is how we will see the kidney stones. This is actually a staghorn calculus in right kidney. So calcifications that we expect in the region of renal fossa correspond to the renal calculi, and those that we see along the urinary tract, that is along the course of the ureter, will correspond to the ureteric stones, and those that we see in the bladder fossa will correspond to the stones in the urinary bladder. So this is a urethral stone. We can confidently say that it is in the left ureter because this is along the course of the ureter. And these radiopaque multiple shadows that we see are actually stones in the urinary bladder. So that is about plain X-ray. Next, we talk about the modality intravenous pyelography. In intravenous pyelography, we use contrast media intravenously, uh, and it helps in depicting both anatomic function as well as physiologic function. In anatomy, it helps to depict the minor calyx, major calyx, renal pelvis, ureter, and urinary bladder. And in physiology, IVP is a wonderful study to assess the kidney function in contrast media, filtration, and excretion. IVP is generally indicated to evaluate mass or assist in urolithiasis, where there is calculi in kidney or urinary tract, for the evaluation of pyelonephritis, glomerulonephritis, where renal function can be assessed, hydronephrosis, trauma, and renal hypertension. IVP is however contraindicated in many cases, especially more so because we use contrast. It is contraindicated in cases of allergy, asthma, anuria, renal failure, cardiovascular disease, severe liver function abnormality, diabetes mellitus, sickle cell disease, multiple myeloma, pheochromocytoma, and pregnancy. This is a film of IVP where we can see a large kidney, and the contrast stays in the renal pelvis and the proximal ureter, and which is abruptly stopped at one point, beyond which the contrast of specification is absent. This is possibly due to a filling defect caused by obstructing calculus in the proximal ureter. So this is how we diagnose the condition of hydronephrosis caused by ureteric stone from IVP. So next we shall see a retrograde urethrography. RGU is generally done to assess the urethra. Here the contrast media is injected from the distal to the proximal part of the urethra. That is why we call it retrograde or ascending urethrograph. Indications include urethral rupture, urethral stricture, congenital anomaly, urethral fistula, urethral diverticula, urethral obstruction, hematuria, recurrent urinary tract infection, slow urinary flow, and urinary mass. RG is contraindicated in acute UTI. So this is how the film of RGU after contrast injection will be, this is the balloon of the catheter in the Foley's catheter in the navicular fossa. This is the portion of the penile urethra. We might see so few radiolucent shadows, rounded shadows in the contrast column, which correspond to the air bubbles within the contrast. Then this is the bulbar portion of the urethra, and we can see that urethra contrast column getting narrowed posteriorly. So then comes the posterior urethra. At first the membranous urethra, which is a very short segment of the urethra, and then more posteriorly the prostatic urethra. Here we have got the impression of the verumentanum in the prostatic urethra. Also, in this video, we can see the filling of the contrast in utricle as well, which is not usually seen. So next modality we shall talk about is ultrasonography, that is the USG. Kidneys are well shown by the USG, and henceforth we can evaluate for mass, cyst, and we can comment whether it is simple or polycystic. By simple, we actually mean only fluid filled anechoic cyst, which is obviously benign. Then we can evaluate for hydronephrosis, stones, and for nephrostomy guiding. So this is the ultrasonographic image of the right kidney beneath the liver on the right side. Here this is the renal outline, and we can see a well-defined hypoechoic rounded mass sitting at the top of the upper pole of the right kidney. So this is how it will we see a renal mass, and which can and then we can report the mass, and whereby the patient can be sent further for further evaluation. And this is how we see a simple cyst in right kidney. This is the USG picture of hydronephrosis. This is the ballooned out renal pelvis, and the ballooning of the major calyces. Also, we can see the thinning of renal cortex here. This is the thinned out renal cortex. So this is these are the USG pictures of kidney, where we see a well-defined a bright spot. That is a well-defined hyperechoic. By hyperechoic, I mean very bright spot casting posterior acoustic shadow. That is how we diagnose renal calculus. Here also there is a calculus, a hyperechoic linear structure casting posterior acoustic shadowing. The distended urinary bladder is also well shown by abdominal ultrasound, and henceforth we can evaluate for mass, stone, inflammation, infection, and diverticulum. And this is the urinary bladder seen by abdominal ultrasound, and here we can see a well-defined polypoid front-like lesion arising from the bladder wall. So then we report it, and then the patient can be taken up for further evaluation. So here we see the ultrasonographic picture of the urinary bladder, and in it we see a very bright echogenic structure casting posterior shadow. This we report it as stone, and also we can check for the mobility of the stone by changing the position of the patient. So finally, I'll be talking a few words about hysterosalpingography. So this is the last modality I shall be talking. about. So HSD primarily demonstrate the uterus and the salpinx. Indications of HSD include infertility assessment, intrauterine pathology, and for assessment of post-operatively the after tubal ligation and reconstructive surgery. Uh, for infertility assessment, we actually evaluate for obstruction in the fallopian tubes, and HSD can also be therapeutic, wherein in those patients sometimes the obstruction can go away after HSD. Then we can also assess for anatomic anomalies such as the Mullerian duct anomalies of the uterus, like uterine biconus. Then by what we mean by intrauterine pathology are those such as endometrial polyps, uterine fibroids, intrauterine adhesion. HSD contraindications include pregnancy, and henceforth HSD is always performed on days 7 to 10 after the onset of periods. And HSD is also contraindicated in cases of acute pelvic inflammatory disease as well as in active uterine bleeding. So these are the images of HSD. The first is the plain film, and the second is where after contrast injection, where the uterus is the uterine cavity. This is actually the endometrial cavity is lined well, and then we see in the third image, the fallopian tubes are beautifully lined by the contrast. So some pathological conditions that we detect by HSG is, these are this is the image of left hydrosalpinx, where we see the left side fallopian tube uh, uh, appearing as a serpiginous distended tube. The last one, the uterus biconus. Here we can see the contrast, a normal triangular shaped contrast column that we expect after opacifying the endometrial cavity is not seen here. Rather, the the triangular shape has been distorted, and we can see uh, the fundal aspect. It is intending more inferiorly. So this is the image of uterus biconus. So thank you.